When I specifically look at hormones for my patients, I like to look at not only the hormone itself and where they're at on serum, but I also actually like to look at the metabolites. The reason why I specifically look at metabolites is that I can make some clinical decisions and I can make some inferences based on what the patient's symptoms are. And not only that, how I can impact them from a lifestyle, nutrition, supplement, medication adjustment. Some of the most common things that I see specifically at the hormone metabolite testing is finding root causes as to why certain symptoms are happening. So looking at a condition like an estrogen dominance, which we might see more symptoms of breast tenderness, weight gain, moodiness, heavy periods. I can look specifically at what pathway that person is favoring, and then I can prescribe or make intervention recommendations on how we can better help lower their risk of higher negative estrogen metabolites that might put them at risk for things like breast cancer or things like uterine fibroids. I also like to look specifically at some of the androgen metabolites, in that when we think about replacing hormones in patients, we want to make sure that we're maximizing benefits while minimizing side effects. And so looking specifically at some of the androgen receptors, specifically the 5-alpha reductase, this can help us understand, will the patient favor a pathway that might give them more negative side effects, looking more at DHT. The other hormone metabolite I also like to look at is progesterone, in that progesterone oftentimes in the perimenopausal phase is in balance with estrogen. And so in a roundabout way, it is more of a progesterone deficiency than an overproduction of estrogen. And that's where the Dutch test can really help us as clinicians identify where is the imbalance and how we can impact that for the patient.